Okay, I would like to invite Dina and Heidi up to the front to take their seats for the panel discussion. And so as per usual, we'll go around and take questions from the forum before opening it up to the floor. And I will give the first question to Peter.
Yeah, thanks very much. Really interesting. And question for both of you, but start off with Heidi. I'm fascinated by this anti-vax movement. And just come back from Australia where there's a similar incident with the Hendra virus vaccine. This is an animal vaccine for horses that, is really critical because there have been repeated outbreaks in horses that then lead to infections in humans and deaths. Really effective vaccine, a great success story with poor uptake. And the poor uptake, Australia's a small population, really based on one blogger who early on started saying, my horse aborted, the symptoms, clinical signs, and due to this vaccine. And apparently it feeds into a long pattern in the horse racing community that horses that have been vaccinated don't perform as well, race horses. So it just led to this, basically a breakdown of the efficacy of that vaccine. Have we failed? Did the Australian government fail to deal with that early enough? And is the same thing true for the MMR issue? Because back in the day when that autism paper first came out, some of the calls around the MMR vaccine were real concerns. You yourself said there's often a grain of truth to this. There's some concerns about a vaccine. Could we deal with those more quickly by setting up trials and giving the public confidence that we're going to test whether this vaccine will, for Hendra virus, cause problems in horses really quickly and get an answer to that, and for other vaccines whether there really are adverse reactions or whatever the myth is. If we deal with them quicker, will that nip them in the bud? Is that a response?
It's interesting you raised this one because I was just asked to review a paper on it. In the last 6 months, I've been asked more and more by the Royal Veterinary College and by animal owners associations in agriculture about the growing anti-vaccine movement by animal owners for their animals, which I had heard on the edges about some pet owners, but these are farm and larger animals. On the Hendra virus one, what really struck me in the paper I reviewed, which I can't cite right now, but I hope that they publish it, it was unlike the human vaccines where people still, even though they distrust everything in the kitchen sink, still health professionals are in this fading confident environment. The health workers, health professionals still are still the top of the people, the top of the trusted informants. And then there's other things. With the animal owners, the vets were at the bottom of the deck. Amazingly, I mean, the comments in the interviews about vets and their just trying to push vaccines, totally in bed with industry, very strong anti-industry, anti-vet, who would you go to for advice? Not the vet. And I thought, there's a problem here. And I don't know if that there's not enough of if they think that it's different with animals than with children. I mean, it is, but it depends if you're the animal owner or not. I think that some of them treat their animals like with the same emotion. But I do know with the Hendra vaccine in this case, it was very new off the pipeline. It was still kind of pre-regulated to just regulated. So there were some anxieties about safety. So that was part of it. We see that in human vaccines also, that some of the newer vaccines are always more suspect. They haven't been trialed long enough. The H1N1, that was a big concern, hasn't been out long enough. You made it too quickly. That concern. I do think we should listen earlier. Sometimes we don't have signals until we're confronted with a problem, but I think there are times where there is a need, and I think particularly in the animal, in the veterinary sphere, now is the time, because this is just the beginnings of signals that there are problems. And with the current environment, with antimicrobial resistance, and the importance of animals being vaccinated as we try to increasingly wean antibiotics, particularly non-therapeutic antibiotics, we'll be in rough shape if people aren't taking vaccines and we're trying to reduce antibiotics or they're not working anymore. So yes, I think in the veterinary space, I think that we need to get much more curriculum for both medical and health, human health as well as animal health professionals. There's zero training on how to deal with difficult conversations. The training is just learning all the information you need to push out there, and there's nothing on the curriculum that has that kind of approach. Not that every health professional needs to get, extensive psychology counseling training, but I do think there should at least be something in there.
Question for Dina, but it also overlaps with comments from Myrna and Monique this morning, which is really a study in contrast that I don't understand. Monique gave us a very compelling argument as to how quickly rumors could actually be interceded and therefore muted. But at the same time, if one then looks at the bizarre, that's the only word one can apply, to the treatment of 8 passive cases of Ebola in the United States, the media were entirely complicit in the spread of panic. No action was taken to refute in any way the nature of the rumors and false information even coming from high government officials. And then you have the ultimate contrast, which at the same time that was ongoing, you had 1 million cases of chikungunya breaking out in the Caribbean basin. I always cynically say it was because chikungunya was too complex a word for newscasters to read, but that's a slightly different off-the-record comment. I mean, for the three of you, why does the U.S. media in particular, and I'm generalizing, seem to be so unable? Is it simply because schools of journalism are now schooled entirely to stoke crisis and controversy?
So it's kind of a complex question. I'm going to try to unpack it in a few different ways. I think you touched on the reality that, first off, you can't say like the media, capital T, capital M. So I have the luxury of, at Scientific American, our readership are particularly science interested. So I can delve into, in our coverage, the complexities of what we know and what we don't know, and even a bit more global health coverage than perhaps some folks might have an appetite for elsewhere. With that said, I don't think it's really a fair comment to say that the media following the few Ebola cases in the United States didn't make any effort to try to, I guess, communicate more clearly what the risk was in the United States. With that said, yes, by and large, there was an undue amount of panic in the United States about everyone's risk of Ebola at a bridal shop or a bowling alley or what have you. And I think that one of the problems is, one, that there wasn't interference fast enough. I think if there had been press conferences immediately to try to dispel the rumors and get information out more quickly about the degree of risk and the real numbers and putting it in comparison, I think if there had been more of a social media campaign, perhaps even like one of those Twitter Q&As where you allow people, everyday Joe Schmoes, to ask questions and get an immediate answer. I think that people had real worries and they didn't know where to look to get those answers. Presenter talked earlier this morning about how a lot of public health entities might think if they put something on the website that they're made in the shade, that they put the information there and therefore it's out there, why didn't you go look, the end. I think one of the ways that can be better addressed in the future is thinking more clearly about the allies that you want to make. Maybe it would be worthwhile to make time to do a Q&A live on television right away, or with a top media publication right away. Maybe it would be worth your time to try to partner with some less conventional partners, whether they be celebrities or someone that just has a really big Twitter following because they're like a YouTube popular person. Even if they're not in the traditional medical space, I think just capitalizing on the realities of people that have a big reach can be useful. Now, I'm not saying that you should make them the authority. I'm not saying like Emma Stone should be who you're looking to for answers about Zika, but I am an actress. But I am saying that, I think having them, let's say, retweet the real information you're trying to get out can be useful, and that if you're doing that on a larger scale, if you already have those partnerships in place, that kind of situation could be avoided more quickly. And that isn't to say that, as far as something like Ebola that has such outsized fear, that is really going to tamp it down. Maybe that bridal shop would have still been closed. Maybe it would have still had that problem. But I am saying that we could shrink some of that concern. And I think there wasn't enough attention paid early on to really hoping to communicate, yes, our information about Ebola is evolving. We don't know certain things, but these are the things that we know for certain. And I think as a public health communicator, for example, Tom Friedan is good about, he starts and ends any speech he gives, if you ever read like a transcript, which I do, with, and the take-home message is X, like, because he really wants to make sure that while he's providing a lot of information, you would get the take-home information, and it might have been, an Ebola concern in the United States as secondary cases is not a priority we should be thinking about right now.
Any comment on the chikungunya void, which is still largely a void?
So at SciEm, we covered chikungunya a lot. So, but again, we have a readership that was more interested. We tracked its evolution more globally, and then when it showed up in the United States and Florida. But I think because it doesn't have the same scary factor, that's one of the main reasons that just didn't get covered. When people think about joint pain, even if it's a longer-term joint pain, they don't think about it being crippling and keeping you from going to work. They don't think about long-term headaches that might keep you from picking up your kids. They're thinking about, oh, okay, so you have a week of flu-like symptoms. That doesn't sound that bad. I mean, that's not fun, but who knows? By the time you realized you had chikungunya, you might have just thought it was flu and you were over it and you returned to work. And I think because of that, that's why it didn't get as much public interest. You're right that the word chikungunya also sounded like something funny. Like, is that a meal? I don't know what that is. Is that on the Mexican menu? What is that? It's unfortunate that the name, I think, was kind of a tipping point for people, but I really do think that Ebola with, the false hot zone-esque type ideas that we had about it, just seems so scary. And indeed, Ebola is scary. Ebola is extremely scary, but chikungunya was not thought of in that same regard. Jeff.
Thank you both for your presentations. They're great. Couple of questions, and you may have answered this as much as you'd like to talk about it, but one question I had was, in the context of acute infectious disease outbreaks, can you give us advice on how to work most effectively with journalists, in particular in the context of what we heard earlier this morning about people who use different media may require different messages, and how we sort of sort through that. And the other question is based on the opening film clip that we saw about trust. And Heidi also mentioned this issue. And when you've got a population that has distrust or dissatisfaction with authority, what can we do during an acute event to sort of manage that? Hard to reach populations who are most recalcitrant are usually the least likely to want to interact with us and tell us what their issues are.
I'll start with the first couple, and maybe you want to weigh in on the trust. So as far as working with journalists, I guess connected to a question you asked this morning about how to better prepare to talk with a journalist ahead of time, I would say one of the main things I would talk about is not being scared if it's not like your exact specialty, which isn't to say that you should speak about something you have no familiarity with. That's no good. But I think it's okay to talk with a journalist when they call you right away and tell you what you are familiar with. Say where your limitations are, but because the story is happening quickly, and if they called you, hopefully it was because you knew something about it. This is a good opportunity to talk about what you do know, what the history of the virus is. Yes, we've never seen something like this before. Yes, we've never seen it in this context. And saying, ahead of time, I think is really useful for an expert to think about like what their take-home message is. the risk is only in X population. We've only seen this in Y cases before. If you want more information, I really think you should look at X resource, just like providing those simple things that the journalist can include in his or her story to like provide some really valuable context they wouldn't have otherwise, I think is important. As far as choosing who to work with, obviously you have limited time, all of you have limited time, and if you get 500 journalist calls in one day, it can be really overwhelming, which I know has happened for some of you with Ebola and Zika and so forth. Obviously, there's, for each of you, you have your own hierarchy maybe of who you would take calls from about, you know, what type of publication, or if it's a local publication, or if it's a journalist you're already familiar with. But I think you might really want to be thinking about what audience each of these publications has, and or broadcast outlets or what have you, about who you want to reach, how big that population is, and where they're likely finding their news. Someone this morning was talking about mommy blogs and how popular they are. If you're writing if you're talking about something that has fetal abnormality risks, maybe it would be really worthwhile to make time for a couple blogs like that, then have a wide reach, even if you've never heard of them before. And similarly, maybe it's useful to think about spreading your time across different types of outlets. Maybe typically you would only answer the phone for like the New York Times or the Washington Post, and you typically don't do that much radio, but maybe a lot of people are driving home from work, and you think that those are the people you need to reach for something about occupational health concerns. And so I think that's just like worth thinking about and strategizing, either with yourself if you have no team, or if you're at an academic institution with your media affairs team. I think that can be really valuable. I also think it's useful to just, in general, have a couple journalists that you have a relationship with. Journalists need to understand information too, and just like you might have someone in mind that you might want to talk to, they hopefully have you in mind too. I know I have certain researchers that I constantly bother, even just for a sniff test. And I know you're all very busy, but even just making time to have like a quick conversation with a journalist, or even respond to emails that is just a sniff test. Like, you looked at this study and you're like, no, that's crap, and here's why. Or no, this isn't a significant finding because we found the same thing 3 years ago. Or yes, this is a big deal, and here's why. It doesn't mean, you can say you don't have time to like do a whole interview or whatever, but just making sure that with everyone's limited time, you're putting someone on the right path, I think is a really valuable resource for the journalists, for the public, and to make sure that everyone's maximizing their time, I think is really great. I have thoughts on trust, but Heidi, you want to jump in first?
Just on in terms of reaching out to the communities, we, in our various expertise, may not be the right people to go into communities, but I think the thing is to try to, in times of peace, as it were, particularly anticipating, say, the next big flu pandemic, to think about who are the people who are trusted in communities. And it's not necessarily the local mayor or the local community leader on paper. In fact, they may be the least trusted, even though they have that official role. It's really just kind of scope out, who are the people, the peers. And with HPV vaccine, for instance, not only do you have the mommy blogs who are up in arms about what they see happening to their daughters or thinking it's HPV, you've got a bunch of teenagers who are, social media is the extension of their fingers, and very in that space. So I would try to find another teenager. I would try to find someone who is a peer, who is in that group. You want them to have the right information. So, in times of not acute emergency, can you do briefings with some of these community people? Aside from, I think it's true, the principle, as with journalists, to build those relationships between crises is the same for community mapping and knowing who the community people are and keeping them up to speed with things as they emerge. CDC has fantastic network across the country. Can the different state representatives kind of know who are the people in certain communities? So we also have a lot of underlying information already of where we have lower uptake of certain interventions in normal times. And they're likely to be the ones where we need to make that extra effort.
I totally agree with Heidi. Just to add to that with a quick comment, I think it's also useful to meet people where they're at, in the sense that if you're willing to share and humanize yourself in this way, to say, yes, indeed, I got my kid vaccinated, or yes, indeed, I had this vaccine myself, because people think, well, if it's good enough for this scientist or this clinician, well, then golly, maybe it's good enough for me. I've written a lot in the past about, the anti-vacciner movement, which so many of you presented great data about today, and, was discouraged to find, even after study show, you try to communicate this way and that way, and it never seems to work. And the only ways that did seem to work were, frankly, just enlisting former anti-vacciners who now, talk to other moms at parent-teacher conferences or whatever and say, yeah, I did vaccinate my kid and it's fine. I won't speak to that data because so many other people have, but I do think, just to reiterate, that if you are willing to talk about your own experience as a parent, if you are a parent or a grandparent, or my sister did this with her kids or what have you, I think that resonates, and I think people feel more comfortable knowing that someone that they view on a pedestal managed to do this thing.
Julie.
I would like to make a comment and one question. My comment is, usually when you teach medicine or any medicine support, the vaccine is not very strong. It's not important to teach all the ideas about the vaccine. For instance, when you present about what happened with the H1N1, in any part of the world, every doctor stop and don't like it to receive the vaccine, only because they request a lot of information. It's impossible to do. When you produce a vaccine from flu, you have only 8 months. And you don't need to make all the studies conducted from other vaccine, but nobody knows that. And they say, no, this is a experimental vaccine. I don't like it to receive. And it's funny, it's the first time the medical community stopped to produce a vaccine. The second part of this is they don't know what is the risk to stop the vaccine. The third part is the gynecologists and the obstetrician stop to have a vaccine from pregnant women from flu. They say, no, this is experimental, they have malformation, etc. And all this is a real misunderstanding. And finally, we never teach how important is the new generation of population. Right now, the people who have more than 65 have high risk to die from pertussis. And this is not important. Right now, the people don't understand the process. We have a new generation who have more than 70, 75. They receive corticosteroids, anti-TNF, chemotherapy, etc. And even their immune state is low. But nobody cares. What is the potential problem when you don't have a vaccine? And that is one of the problems we need to promote, to teaching all the basics idea of how important is the vaccine in the health system and the public health sector. It's not only personal decision, it's a social decision, the impact when somebody have not a vaccine. And my question is, the rumors are very negative in the community. And sometimes the government or the institution delay the answer, 3-5 days, because a lawyer or somebody need to review the paper, somebody need to sign, and that is important mistake. What you recommended to answer the same day, at least the first part of the rumors, you need to put very clear this is not, or this, and don't missing on blind the information. Say, no, this is not important. That is not true, as you mentioned in the slides. This is very important because you have negative, not only from this problem, if from the future problem, you have the negative idea permanent.
Such good points. To your question, I think really a lot of the slow down points about getting information out to the journalists, those need to be cleared up from on high. That's sort of a top-down decision that, let's say an organization makes the decision, we are going to streamline, we're going to have these protocols in place so that when there's an emergency, we're not going to first, run this statement by 20 people and make sure that it's exactly right in that way, which isn't to say you should put incorrect information out, but it should say that you have a couple people that are authorized to speak without 20 layers of bureaucracy stopping them. And that can be a difficult thing in every context, in every country, and whether it be at a local or state or a national level. I don't have a solution for it other than those discussions need to happen ahead of time, that I think, a public affairs team and officials need to sit down and say, hey, we need to be prepared for this next thing, and we've authorized these 3 people at the top that they'll be our spokespersons on this issue, and we'll have a 10-minute meeting, to actually formulate what our message is going to be following we are finding out about something, and then we will react. And to your larger point about, vaccines being new and people being trepidatious and saying it's experimental, and, this year's flu vaccine is different than last year's and so forth, or it's new to this particular community, I think that's just a behavior change point, about standardizing flu vaccines every year, for example, which is something that isn't standard for too many people in the U.S. as well. And I think the behavior change people in here are better poised to speak to how we're going to get there.
Thank you for your presentations. When you were talking earlier about veterinary care, I was thinking back to just recently bringing my dog in for vaccines, and I saw 2 different veterinarians at the same practice and had very different opinions. And sometimes these are very scientific, but I've also had, I'm sure other people have too, experiences with your own clinicians giving bad advice. So I haven't heard too much about how do we reach the clinicians who are providing bad advice. Now, sometimes they can have that same ideological bent, or they're pandering to a certain population for whatever reason. Sometimes they're misinformed, sometimes they're badly trained. There's a whole spectrum, but what's the best way to reach people who should be out there giving the good advice to the patients and everything about vaccines or mammograms or whatever the issue is, but yet they don't believe it or they're misinformed?
We're increasingly doing surveys and qualitative work with health professionals, and I know ECDC, in particular, European Centers for Disease Control, is extremely worried about this. France, they did a survey with GPs just before our study came out that found that nearly 50% of GPs refused or hesitated about at least one vaccine, and that's GPs. So I think the first thing we need to do is understand who they are, because you're going to have, like you do with parents and adolescents, a spectrum of people who are hardline refusers, and then the scope of people in the middle who are just uncertain. And I really think we need to reach the uncertain ones. I think the hardliners are as my friends in the refuser site said, at least she knows you don't waste your time with us. But I think there is this uncertainty, and I think also, to be honest, sometimes it's not even about the vaccine. They're anxious about having to deal with aggression and confrontation and not knowing the answers. And so it's easier to not push on a vaccine and also then to deal with the kickback, as it were. So I think that's one aspect of it too. But the more we can understand by talking to them and asking them through health professional networks or meetings or whatever to try to gather that information more, I think that would be helpful. I was thinking of something else, but it's gone.
Just to build off what Heidi said, I'll rely on what scientists have told me about this in the past, which is they see it as sort of a 3-pronged thing, that there need to be more continuing education courses on this type of thing so that doctors who are, let's say, midway through their career are still discussing these issues, still thinking about it, and hopefully changing their approach with patients. There needs to be more education at the college level about how to communicate about these, and also there need to be sort of constant updates from organizations like AMA to say these are the facts. Obviously, though, really at the ground level, that can only do so much because doctors are people too, and they've looked at science, or maybe they just have their own predilections. And I think some of this responsibility also falls to the patient community to try to find a doctor that they feel is pretty well informed and pretty invested in making sure that they and their community have the best care. And I think that's a difficult thing to get, because we only rate doctors now either by word of mouth, by saying my friend goes to her or him and really likes them, or we look at Yelp ratings now for doctors sometimes. But I think with the Affordable Care Act, now that there is more data being gathered about doctors and their success levels and a variety of information about them, perhaps that'll start changing this in a slow fashion, but longer term.
The history, the length of time, the fact that sort of this anti-vaccine sentiment is really a hardy perennial. It's very well embedded in the system. And I'm wondering, you know, I know that most public health agencies and most groups that really want to see our populations vaccinated have programs for vaccinating people, but I'm not sure that we have a well-organized system of countering this anti-vaccine thing. Is there a well-built sort of overall system? You're providing obviously a lot of information to guide what's happening in various places of the world vis-a-vis this thing, but do we need to build a larger coalition that really works on an ongoing basis, knowing that vaccines have this history that needs to be countered?
There are efforts being made in this area, and SAGE, the WHO Strategic Advisory Group of Experts, became so concerned about this that, partly because countries kept coming to them asking for help, that they set up a couple years ago an advisory group on vaccine hesitancy. Bruce has left, but Bruce Gillen and I were on that group there were 8 or 10 of us, to help think through what do we do about it. We did a number of systematic reviews on what literature is out there on the determinants of vaccine hesitancy and refusal. And then also my group did for SAGE a big systematic review on strategies to address it. In the last 5 years, there's been a real acceleration in the literature on trying to understand the drivers of these issues. We're pretty weak in terms of strategies. There's a lot of stuff out there on communication and ways to build demand, to push vaccines, to health promotion type things, mountains of information on that. But that's not the same. And I think one of the struggles a little bit we had with WHO on this was to say, listen, this is new. We need to kind of clean the slate and say all that great work that's gone on about, mobilizing vaccine campaigns and health promotion and demand creation is great, maybe for the first 85% of the population. This is different. We need to sort of understand what the issues are and build new strategies. So right now, a group of us are building a network of people working on these issues that includes both some interested immunization program managers, research institutes. WHO, UNICEF is also involved with this, to have a bit of a global network so that we can, because there's so few of us to be responsive to the absolutely growing demand on this. It varies by vaccine, it varies by situation, but what we really need is to start piloting new approaches. We have extremely different publics. What we call, best practice to me, have you ever seen a date on a best practice? I remember I worked in AIDS for a while. Some of the best practices in 1984 would have done nothing for us and even in vaccines. The vaccine environment has absolutely changed. The communication environment has absolutely changed. Publics have absolutely changed. We need new things. We probably need new things also for the demand creation and promotion for the people who don't have a problem with this, but we need something new. So there are there's movement in that area, but we really need to do more.
Thank you for your thoughtful comments. There's a bit of a maybe it's an irony, or it could be a sort of an unresolved contrast between the theme here of trends in technology and increasingly diverse means of communication that should be speaking globally, broadly, and yet increasing sort of hyper-local, hyper-focal audience spaces and understanding of audiences, so that all the reality checks seem to be, the person next to me in the supermarket line, or what I do is talk to taxi drivers, and so I'm wondering, how do we realize what ought to be the promise of a digital medium that should allow for a much broader reach and a much broader sense of people that haven't spoken but yet are listening, and understanding what their needs are and how to communicate more effectively to those well beyond our local day-to-day experience. I'm not yet convinced that we have thought carefully about how to take advantage of opportunities that seem to be now instead just, penalties.
So I think people already are voting with their clicks, and not just in a way that we saw with the election and with sort of a binary of what news sources people are reading. I think when you think about the choices we're making, let's say on Twitter or on Facebook, it's already hyper-localizing. The people that follow me, let's say on Twitter, are interested in what I have to say. It's a very specific subset of people. There are tens of thousands of people out there that aren't following me, that are following somebody else, and they are looking, for other information from another resource. So at the same time that there's a lot of noise being introduced, there's also a lot of choosing taking place. And I agree that there hasn't been a lot of thoughtful thinking about it, about how you can best harness these resources to make sure that you're, I guess, expanding beyond your base. But I think, sort of relevant to what I was saying earlier, I think you just need to sort of be constantly thinking about amplifiers. Someone with a giant following who's retweeting you on Twitter, or someone with a giant following who's, sharing on Facebook that there's a Facebook Live presentation from some public health entity right now. And I think that's the way that you can sort of leapfrog into a bigger field and reach people you might not have otherwise reached. And I recognize it's not a perfect thing, because if I'm following some celebrity, maybe it's because I wanted celebrity news, and it's not because I wanted them to tell me a bit more about the flu vaccine. So maybe that person would stop following that celebrity, but hopefully not. Hopefully they would say, well, I believe in the brand of that celebrity, and therefore I want everything that person has to that person represents, and that includes good public health information. I think of someone like Chelsea Clinton, who's become a celebrity for a variety of reasons, mostly having to do with her parents, obviously. But she's someone that retweets science and health information a lot. And she has a large reach because of the platform that she has. And while, there isn't a specific interaction, the journalists aren't asking her to do that, it has an amplifying effect.
Gary.
Well, after listening to this all morning, I'm hearing themes. One is we actually don't know how to convince people to do things, which is fine. The second is communication has changed so dramatically that we're kind of stuck in an old world. And it makes me think that if I need to communicate with the people I need to, I have to hire an expert, a subject matter expert, and a 14-year-old with 3 thumbs. And I think that and I have to get permission from my chain of command, and I didn't want to tell you who the top of my chain of command is, to be able to answer, and not to have to go through a press office, et cetera. And the worrisome thing is, how do you not fall into a chasm? You're a journalist and know how to do it. You've been doing this for a while. If I were to do it, I have the feeling suddenly I would disappear off a cliff. And that would be a problem. So, and I don't think there's any advice anywhere of how to do this right.
Just a quick comment. I think there are actually trainings for scientists about how to use social media. I don't remember off the top of my head where they are, but there's another presenter this afternoon, not to put him on the spot, but at the World Conference of Science Journalists, and he might know. But I think that there, even you can just Google it and see that there are short workshops online and in person trying to help with that.
So I have a question, but I'm going to make a comment first to follow up on that. There's been an awful lot of discussion today on this problem, particularly in the social media space, of effectively a lie going around the world before the truth puts its pants on. And I just wanted to point out that there are, in fact, models of this where this works already. They just all happen to be in the private sector. Private sector companies, Delta, Walmart, all the big corporations, all have social media teams. They are effectively crisis communication teams, but they don't only act in times of crisis. They are monitoring the social media streams for mentions of their companies, so that when something happens, or when something is put out there that is negative to the company, they can jump on it immediately. Now, what private sector companies have, of course, that public health doesn't have is money. And that is a problem. But I think even more than the problem of funding is the trust problem, which is that public health wants very much, for very good reasons, to be trusted. The trust wanting to be right militates against being nimble. And to move in the social media space, you have to be nimble, or the lie will go around the world before the truth puts its pants on. So that was my comment. Seek private sector models. My question, I guess I'm closing out the session, is, Dina, I'm going to use other journalist privilege here and ask, think back to when Zika was starting here in the United States, which is almost a year ago, because the first case in the continental United States was on, I think, the 11th of January. What would you have wanted differently from public health agencies in those first couple of months that would have made your coverage easier?
That's a great question, and one I've actually thought a fair bit about, as I'm sure you have as well. So with Zika, we obviously had the benefit of Ebola being very still in our close rearview mirror, and so people were thinking about how to respond differently than they did with Ebola. With that said, Zika actually, so a few things. One, Zika, they didn't allow for enough uncertainty. Early on, when public health officials were talking about Zika, they were very definitive in their comments, saying, this is only mosquito-borne, it is not sexually transmitted. And they didn't even mention that, there was already a case in the literature from 2008 or 7 of one instance where a gentleman thought that he had sexually transmitted Zika to his wife when he was doing field work in Senegal and came back to Colorado. So there's no mention of that at the time. And I understand, in the context of you're trying to go through a lot of information at once very quickly, maybe they didn't think that was at the top of the list. But in the weeks and even months that followed, that could have been mentioned. Obviously, journalists like myself and probably you and many others found it, but that could have been given out. It bothered me similarly that CDC wouldn't share information that they had about prior Zika cases that had occurred dating back to 2007, which is why I called the 50 state health departments. But throughout my time doing that, I would circle back with CDC each day and say, hey, I've reached 37 states and I have data on them. You don't want to just give me the remaining states? And they're like, sorry, and there are various legal and privacy reasons for that at the time before they got Zika and ARPANET, but I found that frustrating. And also I would say, sometimes I think we all need to get our heads on straight a little bit about where privacy versus public health concerns meet, in the sense that the first early reports that came out were from the states and not from federal entities about cases of Zika that were that were occurring that maybe were confirmed or maybe weren't confirmed at the state level, and I think that led to some ambiguity and confusion, as federal resources would say, well, a state said this, and the state would say, oh, we're referring to CDC for confirmation of these cases, and I think while that's maybe a little esoteric for this audience, led to sort of a slowdown and some confusion. So I think in future outbreaks, I think it's still useful to keep thinking about how we can respond more quickly, how we can respond more openly, and how you can get public officials on the horn to give press conferences more quickly, and not just to the US audience, but also to a global audience as well.
All right, so I said a bunch of things earlier that are critical of risk communication, and they were meant to tamp down some of our enthusiasm for the idea that risk communication can solve our problems easily. It is true that we can change risk beliefs, that they're hard to change. The risk beliefs are associated with behavior. That's a good portion of my career showing that. So we know that. That's not surprising. But the point is that it's a relatively small thing. Science, there is a science to communication. It's difficult. If it was easy to change behavior, we would just snap our fingers and do it. A trifold brochure is not going to change the world of anything. And yet at the same time, organizations have to communicate. They don't have a choice. Not communicating is a worse option. The science is slow, but the problems are fast. So I appreciate that we have some concerns about the robustness of what we can do, and at the same time, we will have to do something, and hopefully science can offer some insight. I want to ask a question of Heidi, it's a twofold question. One was about the role of confidence. So what I like about confidence as a construct is it's not so much about the hazard or the threat, which is what we were talking about this morning, but more about the behavior, which is a little bit of what Jeff Nieder-Deppy was talking about. So confidence is your confidence in the behavior or the prophylaxis or what have you, so vaccine in this case. So that could be associated with individual behavior, and I'm a little skeptical of that having a strong influence. But it could very much have a strong influence on the policy. For example, the cratering of the HPV vaccination program in Japan because they didn't support it. I'm very concerned about that, and that does seem to be where confidence failed at the policy level, where there was the absence of confidence was not there to support it, in the way where, for example, in the UK with David Salisbury and others, when they had a crisis in HPV vaccination, the confidence was there. So I'd love to hear your comment about where you think, do you think confidence is playing a role in policies more than individual behaviors? The first question. The second question is if you can provide maybe some positive examples or just a positive example of where we're doing a good job in supporting confidence as maybe a positive lesson.
That'll keep me brief. It's a very good point about confidence and what we talk about in the Confidence Project about the 3 Ps. Trying to simplify our narrative. Confidence in the product, in the provider, which could be, the health professional or the service, and the policy and politician. And they are really, when I was talking before about multiple levels, it's like a trust chain. And if you're missing a link in the chain, you can have all the trust in the product, but the gatekeeper discourages you, and you don't want to go back to that health center. Or the policy you find imposing or mandate or whatever. So I think you need all of them, and our confidence index integrates some of them. We found in the 2015 study. There's a lot of rhetoric that says, it's health system. If the health system is better, people are going to do better with vaccines. Well, there's not a lot of data on that, actually. And in our study, it was a 5-country study, a reasonable amount of households. We saw absolute correlation. The higher confidence in the health system, the lower the vaccine hesitancy. And the 5 countries we did last year were India, Pakistan, UK, Georgia, and Nigeria. These were 5 countries that each at different times had negative vaccine events. And it was just to get a sampling. I mean, this year was 67 countries, so we have a much broader reach, but it was really striking. There was no country that did not have that strong correlation. So I think we need to look at all. I thought you said there was a second question, but I think it was different parts of the same question. Did I? Oh, positive examples, that's right. I wrote an article for Nature, I guess it was the end of last year now, following Denmark, to this day is still very anti-HPV, has a strong lobby, lobbied the European Medicine Agency, the European FDA, to re-review the safety profile of the HPV vaccine. And as soon as that came out, there was a Nordic Cochrane statement that just said, this is rubbish. This anti-vaccine league said, it's rubbish. They're not accepting, there's still debates going on. So I wrote, Nature asked me to write a piece on what's going on, and I looked at 4 countries and how they all reacted differently, and 2 stood up to the science and 2 bent to public pressure. They were all about these psychosomatic reactions among young girls, from several hundred in Colombia to initially 12 and then more in Japan. Japan and India either suspended or shut down their programs because of activists. The politicians were paralyzed. The UK, as you mentioned, and Colombia stuck to the science and soldiered on. Now, I have to say, UK is doing well with HPV vaccine. Ireland is going off that chasm that you referred to. They have a strong anti-mother group called Regret. Actually, it's mothers and fathers. And we're about to lose their success rates. But England and Scotland are doing great. Colombia is suffering. I mean, the Minister of Health was really so emotionally shattered by the aggressiveness of the community. He actually got a helicopter. He was going to go into the community and talk to them. The president had contacted him the night before to say, what do I say about these 600 girls? And he wrote something very briefly, so he didn't realize that when he got on that helicopter, the president had just said, don't worry, this is psychosomatic, basically they're crazy, was the interpretation. So when he got off his helicopter, the aggressiveness of the crowd, they had to bring in the army, they had to escort him away. They didn't have the town hall meeting. He did have some individual meetings, but they stood by the science. So what do you do in a situation where it's a success at a programmatic level, held his ground, but the acceptance rates are still quite low because there has been a hugely proactive, a lot of anti-HPV from the US that are being subtitled. Google Translate is not helping us in this matter. It's great for some things, and Google Translate, by the way, it's pretty good in French, but there's a lot of other languages that it's less good at, and a couple words get lost in there, which adds to the Chinese whispers and the rumors. But a lot of US stuff I saw with Spanish subtitling circulating among the young girls, and that has been very proactive, keeping the acceptance rates down. So I think success, England and Scotland, they've done great, and I think it speaks to England having been beaten up pretty badly over the MMR. And I think without the MMR, I don't know if they'd be doing so well with the HPV situation, but they're doing well. And thank you very much. I have a flight to India.
Please join me in thanking both Heidi and Dina.